All right, colleagues, welcome. Today, we're diving into a clinical challenge that I'm sure we've all faced, the prophylactic management of recurrent erysipelas. Getting this right is absolutely crucial for our patients, so let's break down the most effective strategies we have at our disposal.
So first things first, what do we even mean when we say recurrent? Well, you'll see guidelines that throw out numbers like 2 infections per year, or maybe 3 episodes in just 6 months. But the truth is, there isn't one single hard and fast rule. This variability really underscores a key point. At the end of the day, it's our clinical judgment that matters most in identifying a pattern that warrants intervention.
So, why are we so focused on preventing these episodes in the first place? Well, the reason goes way beyond just treating a simple infection. It's really about interrupting a truly destructive cycle.
Here's the concept we have to internalize. Each bout of erysipelas is not just a standalone event. It's a direct assault on the patient's lymphatic system, which, as you know, is vital for local immune defense. Every single relapse causes progressive, cumulative harm, and this creates a really dangerous feedback loop.
And here is that vicious cycle laid out. You get an infection, which in turn damages the lymphatic vessels. That damage then weakens local immunity, and of course, that compromised defense system creates the perfect setup for the next recurrence. Our entire goal with prophylaxis is to shatter this cycle.
So how do we actually do that? How do we intervene? Well, from a pharmacological standpoint, we really have 2 main strategies we can employ: a continuous long-term approach or a patient-initiated on-demand therapy.
For continuous therapy, oral penicillin is a real workhorse, usually prescribed daily for at least 6 to 12 months. Other solid options include intramuscular penicillin every few weeks or daily amoxicillin for a year. And of course, for our patients with a penicillin allergy, clindamycin is the go-to alternative. Now, this whole approach stands in pretty stark contrast to the on-demand strategy.
And naturally, anytime we're discussing a long-term antibiotic regimen, like the ones we just saw, the principle of antimicrobial stewardship has to be front and center in our minds. It's a critical piece of the decision-making puzzle.
The on-demand strategy is a really interesting model. It's all about patient empowerment. The whole thing rests on having a well-instructed patient who knows how to recognize the very first signs of an episode and can start their antibiotics immediately. This allows for the absolute most rapid intervention possible.
But listen, pharmacology is only half the battle. To have any hope of long-term success, we have to look beyond the prescription pad. We have to aggressively manage the underlying predisposing factors that are driving the recurrences in the first place.
Now, you could argue that the single most important non-pharmacological intervention is treating edema. That means compression therapy for venous insufficiency and lymphedema. But it doesn't stop there. We also have to be meticulous about correcting any breaks in the skin barrier. That's everything from ulcers to dermatomycosis. Managing colonization is also key, though it is important to remember that nasal decolonization with mupirocin is mainly for staph issues, not streptococcal erysipelas.
And this really gets to the heart of the clinical reality, doesn't it? While we can make a huge difference, managing these chronic underlying conditions is a persistent challenge. It requires constant vigilance, not just from us, but from the patient as well.
All right, so we've covered the core principles. Now, let's see how this all works in practice. We're going to walk through a few clinical scenarios to test that knowledge.
First one up. Imagine this. A patient is in your office. They've had 3 distinct episodes of erysipelas in just 7 months. So what's the threshold that should immediately make you consider prophylaxis, and what oral agent is likely your first thought?
So, let's walk through the thought process here. We have to fall back on the established guidelines for initiating this kind of therapy. While the numbers might seem a little arbitrary, they're there for a reason, to help us spot a clear pattern of recurrence that screams for more proactive management.
So the answer here is pretty straightforward. With 3 episodes in 7 months, this patient easily clears that common threshold of 2 or more infections per year. And for continuous oral therapy, Penicillin is a very common and appropriate first-line choice.
Okay, let's move on. Case number 2. We've got a patient with recurrent erysipelas, but this time they also have chronic lymphedema. How does this one crucial comorbidity completely change your prevention strategy?
The guiding principle here is that we can't afford to see comorbidities as just another line on the patient's chart. They can be the primary drivers of recurrence, and in the context of erysipelas, lymphedema is one of the absolute most significant drivers there is.
Because lymphedema is such a critical predisposing factor, our approach has to be integrated. It's non-negotiable. Any prevention strategy must include compression therapy. If we just prescribe antibiotics while ignoring the underlying edema, we are simply setting that patient up to fail.
All right, final case. You have a patient, and you've both decided that on-demand therapy is the right path. What is the one single most critical element that this entire strategy's success hinges on?
The on-demand model is a fundamental shift in responsibility. It's a true partnership. The success of this approach is no longer just in our hands. It hinges completely on the patient's ability to act correctly and, just as importantly, to act swiftly based on the clear instructions we provide.
So the answer is, without a doubt, a well-instructed patient. Their ability to recognize those very first symptoms and immediately start their course of antibiotics is what makes this entire strategy work. If they hesitate, that critical window for early intervention is lost, and the strategy falls apart.
And I think this quote synthesizes our entire discussion perfectly. In the world of infectious diseases, an ounce of prevention is worth a pound of cure, or perhaps a kilogram of penicillin. Proactive management of both the infection and its underlying drivers is paramount. Thank you for joining me for this explainer.